Okay guys, so in the last lecture we looked at the pathophysiology of gas exchange, and in this lecture we'll talk about our approach to respiratory failure, starting with the pathophysiology and then working our way through the causes, clinical features, and finally the treatment. So just to remind ourselves of the objectives, some of which would already have been covered, you can pause the video and just remind yourself of what we're trying to learn here. Okay, so let's look at the factors affecting the concentration or the partial pressure of CO2 in the blood, PCO2. Briefly, let's remind ourselves of the characteristic of this gas. It's highly soluble. It diffuses readily across membranes. It's produced in the tissues as a byproduct of tissue respiration and excreted in the lungs. Because this gas is so soluble, once it gets to the lungs, it can usually be excreted once there is sufficient ventilatory capacity in the lung. We're talking here about global ventilatory capacity. So once the minute volume is high enough, the gas can diffuse and be excreted. If, however, the minute volume is not high enough, so for example in airway obstruction, CNS depression, or musculoskeletal diseases affecting the muscles of respiration, then the actual exchange of air in the lung, so the replacement of air in the alveoli, can slow down enough that the removal of CO2 from the alveoli is affected. The CO2 rises in the alveoli, and if you remember from the last lecture, the diffusion of CO2 from the capillary to the alveolus depends on a diffusion gradient. So as that CO2 rises, the diffusion gradient is lost, and CO2 must rise in the capillaries, leading to a high PCO2 in the blood. Now let's think about if we have a situation where there is poor ventilation in some parts of the lung but not others. Well, because CO2 is so soluble, the parts of the lung that are being properly ventilated can make up for the parts of the lung that are not. So you might have bits of the lung in which there is poor ventilation, or conversely poor perfusion, and therefore either blood is not getting to the alveoli, or the alveoli themselves are not working properly and can't take part in any gas exchange, CO2, oxygen, whatever. However, although those parts of the lung are not working, because CO2 is so soluble and diffusible, the excess CO2 that might build up because those parts of the lung are not working can be got rid of from the parts of the lung that are working. That is often compensated for by an increase in respiratory rate and an increase in minute volume. So if we have patchy areas of poor ventilation or poor perfusion, but the rest of the lung is working, often what we see is that the patient starts to breathe a bit faster, and that gets rid of the excess CO2. And that's really because the CO2 is so soluble and diffusible that the healthy lung can compensate for the lung that is not taking part in gas exchange. Now this is very different from oxygen. With oxygen, remember we said it's not a very soluble gas, and therefore ventilation and perfusion abnormalities can affect it. Basically, oxygen concentration or transport in the blood blood is limited by the ability of hemoglobin to accept oxygen and therefore can be saturated. Of course, if there's hypoventilation and not enough fresh air is getting into the lung, so that there's not enough of a supply of oxygen, just like with CO2 building up, oxygen levels will fall. So hypoventilation is a cause of hypoxia. However, because oxygen is affected, or the transfer of oxygen is affected by diffusion, anything that affects diffusion, such as fluid in the alveolus, thickening of the alveolar membrane, loss of alveolar surface, such as in emphysema, all of these things will affect diffusion of oxygen and can lead to hypoxia. As we were alluding to with the CO2, if there's a mismatch between ventilation and perfusion, so for example, if there's an area of the lung that is perfused but not ventilated, or an area of the lung that is ventilated but not perfused, or patchy areas where some areas are perfused but not ventilated and other areas are ventilated but not perfused, then if there's not a match between the blood flow and the oxygen supply, because the oxygen capacity is saturatable, in those ill areas we're not going to get oxygenation, but that cannot be made up for by in the areas that are working well, because the areas that are working well, by the time the blood passes across the alveolar membrane, it is fully saturated. So those areas can't take up more oxygen to make up for the areas that are not being oxygenated or perfused. That's the basis of ventilation perfusion mismatch. Just to mention some terms to you. So you'll hear the term shunt. An area of shunt means an area that is being perfused but does not get proper ventilation. So for example, an area of atelectasis. Then you'll hear another word, dead space. Dead space is an area of lung that is ventilated but is not being perfused properly. For example, a segmental pulmonary embolus, there's no blood flow to that segment, but the lung may still be ventilated. And those are the two main mechanisms behind ventilation perfusion mismatch. Finally, a low FiO2 can lead to hypoxia. So if a patient is breathing oxygen with low partial pressure, air with low partial pressure of oxygen, they will also become hypoxic. Okay, with those principles in mind, let's think about different types of respiratory failure. Let's start with type 1 respiratory failure. So, as we said, this is characterized by hypoxia with either hypo or normocapnia. So, the lung is being ventilated usually, but oxygen is not getting into the blood, either because of diffusion abnormalities such as fluid in the lung, pulmonary edema, or thickening of the alveolar membrane, hyaline membrane disease or ARDS, or mismatch of ventilation and perfusion in conditions such as pulmonary embolism, atelectasis, ARDS, asthma, bronchopneumonia, anything in which there are areas of the lung that are ventilated but not perfused, and areas of the lung that are perfused but not ventilated. And then we talked in the last slide about shunt and dead space. And as we said, because there are parts of the lung that are still working, and the lung can ventilate itself, these conditions cause hypoxia because oxygen can't diffuse adequately, but they are associated with either normocapnia or hypocapnia because ventilation is maintained globally, and therefore we're still getting rid of our CO2. And of course, some of these conditions cause an increase in respiratory rate to try to compensate. And if we increase our respiratory rate, we blow off even more CO2. So these patients can actually be hypocapnic. So how do these patients present? Well, usually they're in respiratory distress, and we would expect hypoxia. The blood gas will also show hypocapnia or normocapnia. And then we'll get signs of the underlying diseases that we talked about before: pulmonary embolism, cardiac failure, pulmonary edema, pulmonary fibrosis, etc. Principles of treatment are that we should supplement oxygen, maximize oxygen transfer, treat the cause, and provide ventilatory support. What about type 2 respiratory failure? So this is characterized by hypoventilation or low minute volume, hypoxia, and high PER capnia. Causes would include CNS depression leading to hypoventilation, neuromuscular diseases affecting the respiratory muscles, Guillain-Barré syndrome, spinal cord injuries, drugs that affect the neuromuscular junction, abnormalities of the chest wall that restrict ventilation, airway obstruction, in particular upper airway obstruction, but also chronic severe lower airway obstruction such as COPD, and then situations in which there's a high FiCO2. It's unusual to have a high FiCO2, but it can be seen in iatrogenic situations, such as when we're using certain ventilator circuits that allow rebreathing of expired air. If we don't know how we're using that, they could cause a high FiCO2. The patient may have respiratory distress, but may not, because they may be hypoventilating due to CNS depression. They often have lethargy or exhaustion with a poor respiratory effort. The blood gas is characterized by hypoxia and hypercapnia, and there may be clinical evidence of the underlying disease. Treatment includes supporting ventilation, supplementing oxygen, improving oxygen transfer, for example, by reopening alveoli using CPAP, and of course treating the underlying cause. Let's have a look at our patient again and see if we could work out what's wrong with him. Remember, he was renal failure with what sounded like shortness of breath, drowsiness, and exhaustion. His pH is low, his CO2 is low, it's high, sorry, his PO2 is low, and he's a bit of a metabolic acidosis. So this would fit with a type 2 respiratory failure, likely due to a combination of poor diffusion because of maybe pulmonary edema and his exhaustion reducing his respiratory effort. If you have any questions, you can bring them up in class. This was our second talk on respiratory failure, and we covered type 2 respiratory failure, its causes, clinical presentation, and treatment. I hope you found this useful. Thank you.